Thank you so much. That was a wonderful presentation. And now we will hear from Dr. Machtinger about trauma-informed care and the role that it plays in quality of care for people with serious illness.
It's really an honor to be here today. Good morning. I'm just going to practice with this for a second. I go back? Yeah, okay. So trauma-informed healthcare is a powerful tool to address some of the most daunting challenges in medicine. It can bring healing to people with serious illnesses. It can increase satisfaction and joy for providers of care. And ultimately, it can be a pathway for us to more effectively address the disparities in health outcomes in our country. So my awakening to the impact of trauma on health and behavior came with the death of one of my most beloved patients. So Rose was a 49-year-old African-American, soft-spoken, lovely, resilient woman with HIV who suffered from crack addiction and a viciously abusive relationship with her husband. And in the end, her husband lured her away from where she was hiding and killed her, most likely because he knew that this time she was really going to leave him. And it was very painful for us because it felt like we watched this happen and at that time felt powerless to do anything about it. After anybody dies at the Women's HIV program at UCSF, our staff and providers come together for a case conference to mourn their death and to try to learn from what happened. And of the 10 recent deaths in our program, 2 were murdered, 2 committed suicide, 2 died from accidental overdoses, 2 died from addiction-related organ failure, 1 died from pancreatic cancer, and 1, Pebbles, was a 22-year-old African-American woman who had just delivered her first baby girl and who became hopeless and depressed and stopped her antiretroviral HIV medicines and died from a completely preventable opportunistic infection of her brain. And we knew these women really well, and they were all quite different individuals. But their stories were all united in having lifelong histories of trauma that contributed to them becoming infected with HIV in the first place, and then led to their deaths directly in the cases of Rose and Amy, and then through substance use, depression, and hopelessness in most of the others. And after Rose died, we did the same thing, but we broadened it. We convened a conference of all the agencies and people who knew and loved Rose, which was a lot of people in San Francisco, to understand what happened and what we can do better. And what we realized was that the biomedical focus of HIV care, like so much care of serious illnesses, is incredibly important, but it's profoundly insufficient. And we realized then, at that moment, and committed that we needed to transform our clinic to one that addresses trauma. So as we did the research and advocacy necessary to make this change, we had 3 epiphanies about the impact of trauma on health and behavior and on us as providers of care. And I'd like to share those epiphanies with you. So the first is it's not just HIV. Most of the serious social and health and social conditions that contribute to health disparities in this country are strongly correlated with individual, family, and community level trauma. So by trauma, we mean an event, a series of events or a set of circumstances like childhood or adult physical, emotional, or sexual abuse, neglect, loss, intimate partner violence, community violence, and importantly, structural violence, like racism, sexism, homophobia, transphobia, and xenophobia, that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects. And the impact of this trauma on adult health and well-being is well documented and startling. And let me share, I'm just going to share a few of the studies of many. So the seminal Adverse Childhood Experiences Study, the ACE study, included 17,000 predominantly white, working class, middle class actually, insured working adults who completed surveys about 10 categories of childhood abuse, neglect, and family dysfunction. The studies found remarkably high rates of adverse childhood experiences and that ACEs, in a dose-dependent fashion, were strong predictors of the major causes of adult morbidity, mortality, and disability in the United States. So, for example, those individuals who reported 4 or more ACE categories had 1.6 times the rates of severe obesity, almost twice the rate of heart and liver disease, twice the rate of COPD and stroke, greater than twice the rate of smoking, greater than 3 times the rate of depression, 6 times the rate of attempting suicide, 7 times the rate of alcoholism, and 10 times the rate of intravenous drug use compared to those individuals who reported no ACEs. And this ACE study only looked at the contributors of childhood trauma. Adult trauma, like intimate partner violence, rape, serious accidents, PTSD, have all been also shown to have a dose-responsive relationship with many of the same conditions. And the ACE study, here's the ACE study, and it's looking at childhood, individual, and family-level traumas. And the ACE study also didn't examine the impact of community-level traumas. And so to fill this gap, the urban ACE study, the Philadelphia Urban ACE Study, used a similar design as the original ACE study to assess the impact of 5 adverse community environments, which is a different type of ACE. And the ones they looked at were experiencing racism or bullying, witnessing violence, being in foster care, or living in an unsafe neighborhood. And people who experienced 3 or more of these community-level traumas as children were more than twice as likely to smoke cigarettes as an adult, more than twice as likely to be depressed, greater than 3 times more likely to have a substance abuse problem, and 4 times more likely to have an STD compared with those with no ACEs. And these, again, are separate and additive to those of the individual and family-level traumas. So understanding this data, for me, clarified why the HIV epidemic looks the way it does and why our patients in our clinic were dying from the conditions they were. So just consider who's affected. 69% of people newly diagnosed with HIV are African American or Hispanic, despite those combined groups representing 30% of our country. Among Black gay men, the HIV prevalence is 30%. 1 in 2 Black gay men are expected to be diagnosed with HIV in their lifetimes. More than half, 1 in 2, transgender African American women are estimated to be living with HIV. So there is no biologic predisposition to HIV. The disparities in HIV infection rates are due to the lived experiences of African Americans, Latinos, and gay people in America that we know include high rates of individual, family, and community-level trauma. So in other words, HIV is a symptom of the much larger and more insidious reality of trauma. And the same is true for the other conditions underlying health disparities in this country. So just a few. African American women have 3 times the rate of pregnancy-related mortality and double the infant mortality rate compared to white women. Hispanic children have the highest rates of childhood obesity. Native Americans have twice the rate of smoking and diabetes compared to whites, and among the highest rates of suicide in the country. These outcomes also aren't biologically determined. It's the same lived experience of individual, family, and community-level traumas that fuels the disparities in the rates of most other serious illnesses in this country. So our second epiphany was that while trauma makes people more vulnerable to certain conditions, it continues to act as an obstacle to effective treatments of those same conditions. So this demystifies why so many medical conditions are stubbornly refractory to supposedly effective therapies. So the difficulties we have as practitioners helping people lose weight or stop smoking, even in the face of serious health consequences like diabetes or lung disease, can be explained in part to high rates of co-occurring trauma and PTSD that are going unrecognized and unaddressed in their care plans. And our third epiphany was that our clinics and our environments of care often mirror the trauma experienced by our patients. Staff and providers often feel overwhelmed by and unsupported. And as a result, they can sometimes be dismissive or reactive and not able to be patient or really present. Patients who have a history of being coerced by an intimate partner or experiences in the foster care system or the criminal justice system often feel unwelcome or unsafe in such situations. And in this way, our clinics can be trauma-inducing for patients, pushing them away from the care that they desperately need. These trauma-inducing environments also contribute to burnout among staff and providers, many of whom have histories of trauma themselves. So as we absorbed the weight of what we had learned, we asked ourselves, if trauma is such a powerful determinant of health and well-being for both patients and providers, why is it so often ignored? So I think the biggest reason is learned. When we see something wrong in medicine, we're taught to fix it, to make it go away, to move on to the next thing. And the problem with the breadth and impact of trauma is you can't just fix it. And as a result, the instinct for providers is to recoil from it, to consider trauma as something outside the realm of our care and responsibility. And so this fundamental driver of disparities remains invisible. So Rose's death and our new understanding about the impact of trauma made us determined, though, to move beyond these obstacles and translate these epiphanies into actual changes in our frontline clinic. We set about to create a trauma-informed clinic. And what we discovered along the way was the model that we created and helped develop is applicable to a wide array of serious illnesses beyond HIV. So to accomplish this change, we looked back from the lessons in the early AIDS epidemic. So early AIDS patients were also from highly marginalized populations and faced a stigmatizing, often uniformly fatal illness. Clinicians at that time didn't have the expertise or tools to effectively fix the problem in front of them. No one did. And many parts of our political system were actively, consciously making things worse for those patients with AIDS. However, we learned, we adapted, and ultimately, the response to AIDS in this country was quite successful, both biomedically and more relevant to our discussion today, by creating new approaches to providing care. The response to AIDS offered us a number of promising ways to practically address trauma and, by extension, disparities in health more broadly. And I'd like to highlight two of these lessons from early AIDS that helped us as a frontline program transform our clinic to one that addressed trauma and disparities. So the first is the power of partnerships. One of the most powerful contributions from early AIDS, because we really did not have the tools to help our patients, treat our patients or help them heal, was to break down the barriers between our clinics and community organizations. And we began to practice literally side by side together in clinic, taking care of the patients. These partnerships reduced isolation and reduce isolation for us as providers. And they offer powerful avenues of healing for our patients. So I'd like to share a couple examples on the ground of a few of these partnerships and how powerful they were to help us actually change the delivery of care in our clinic. Our first partnership was with Nana Khanna, who's the executive director of the Positive Women's Network USA, which is the largest body of individuals advocating for and run by women living with HIV. And they too had seen the devastating impact of trauma on their individuals in their group and were eager to see a health system response to it. So Nana and I together realized that there was a lack of guidance for a trauma-informed approach to healthcare. And together we co-convened a national working group of 27 representatives from the military, from governmental agencies, the NIH, academia, community organizations, and people with lived experiences of trauma. And the model that emerged from that conference and follow-up meetings is grounded in evidence-based interventions, expert consensus, and input from patients with lived experiences of trauma and serious illnesses. It has 5 domains. I'm not going to go into each of these explicitly, but in general, the domains are environment, education, inquiry, response, and foundation. And what we found are there are many evidence-based interventions in each of these categories. And the state of the field now is understanding how to package them into something that can be practically adopted by frontline clinics, and determining what combination is most acceptable to providers, most efficacious, and most cost-effective. And our program now, in collaboration with a number of programs throughout the country, is in the midst of a prospective mixed method evaluation of this model to help answer many of these questions. And more information about the model and toolkits to help implement it are embedded in links on this slide. And I'd like to say two more things about this. The model builds on decades of work developing effective health system responses to intimate partner violence, which is one type of trauma. And the group included a number of leading voices from that field, including Lisa James from the organization Futures Without Violence, Lee Kimberg, a real leader in this movement from UCSF, and Bridget McCaw, who leads this movement for Kaiser Permanente. The group, importantly, also included a woman by the name of Lark Huang. Lark is the director of the Office of Behavioral Health Equity at SAMHSA. So Lark and her longtime colleague Mary Blake have taken the lead federally, working to integrate trauma-informed approaches into care across many different fields of medicine from their position of influence. So one more partnership I'd like to highlight. This was an incredibly helpful clinical partnership with a woman named Rodessa Jones. So Rodessa is the co-founder and co-artistic director of the community arts organization, the Medea Cultural Odyssey, and the Medea Project, Theater for Incarcerated Women. So Rodessa led an expressive therapy intervention with our patients using theater and writing. And it was by watching and studying her method that I learned for the first time that people can heal from even the deepest wounds of trauma if offered the appropriate types of therapies. Our research of her method, which is described in categories on the right-hand part of that slide, allowed us to better understand the ingredients for such a change that we can now apply to other interventions that we're developing in clinic. And this is an example of how a partnership within a community organization can build on the strengths of an individual community in which you are working and extend the reach of a clinic and offer treatments and healing that are different from and offer often far deeper than what is available in standard clinics. So the other pathway and lesson from the successful response to early AIDS is the power of engaging and integrating peers into care. Peers offer opportunities for patients to support each other's healing in ways medical providers cannot, and can help guide the medical system's response to their own needs. For us as providers, integrating peers jump-started a different way of thinking about patients from others to something more like partners. In our clinic, we started with focus groups and over time have evolved incrementally towards a more integrated approach for peers that includes a bi-monthly stakeholders meeting with representatives of each discipline in clinic and 4 patients who meet to discuss the various options for the rollout of our care model. And they guide the various interventions we're implementing. So over time, our peer programs have increased. We now have a peer-led support group. We have a peer-led intervention for co-occurring substance use and trauma, and a peer-led leadership council that allows for post-traumatic growth. And recently, for the first time, we hired one of our former patients as our new social worker, which was a long-time goal of the program and in itself feels like a sign that our commitment to change is real and long-lasting. So, it's important to know that the model is aspirational and can be implemented incrementally. We've seen that even small steps can be felt very powerfully as clinics move from being trauma-inducing to trauma-informed to trauma-reducing for patients, staff, and providers. And it's really hard to convey how different our clinic feels now that we have incrementally adopted each element of a trauma approach to care. So last week, I saw 3 patients in a row who openly discussed their struggle with crack addiction. We were able to work together to imagine ways to use less and use more safely as they continue to use. It was clear that these individuals felt safe enough with our clinic and safe enough with me to reveal themselves and ask for the help they needed. They felt respected, seen, understood, liked, and even loved enough to disclose something that is almost universally felt as shameful. And the victory here is that it allows us, as a standard healthcare clinic, to more effectively address the smoking, medication non-adherence, substance use, and other trauma-related conditions that fuel most of the disparities in health outcomes, but have long been considered outside the realm of our expertise and responsibility. So in conclusion, why does trauma-informed care matter in this room today as we discuss health disparities? I believe that adopting a trauma-informed approach is the best way for us as clinicians in healthcare settings to meaningfully address the social issues that we know underlie most disparities in health. Trauma-informed healthcare provides a pathway to fulfill the calls made by Bridget, Marshall, and Kimberly to change the culture of healthcare to one of health equity and the nature of communication and relationships to one where patients feel safe, respected, and cared for. If we are going to begin to dismantle health disparities in our country, we're going to need to broaden our perspective of care from one that just focuses on treating symptoms and diseases to one that includes healing. Individual, family, and community-level trauma are most often what stand in the way of healing from conditions that underlie health disparities in this country and in the way of forming genuinely healing relationships with you. So it's not radical to think that our role as healthcare providers and the reason why we went into our various disciplines of health is to help people heal. That's not radical at all. It's self-evident, but it's been taught out of us. And what we're trying to do in this movement towards trauma-informed healthcare is to teach that back in, is to help people realize their vision for why they went into this in the first place, which is to help people heal and to connect with people and to heal themselves in that process and to have joy in that process. And I believe these experiences are necessary for both patients and providers if we are ever going to be able to meaningfully move the needle on health disparities in this country. I'd just like to acknowledge the passion and wisdom of our research and clinical teams and the courage and trust of our patients. I'd like to thank you so much for inviting me here today. I'm excited to have this conversation and see how this framework could be relevant to the important work that you all do. Thank you so much.
Thank you.